The one that's far and away the most important and provides the most useful data is the most recent of the trials. It's called the RESPECT trial, and again it uses the St. Jude device. And there are problems with the study as well. I consider it underpowered again. It was an endpoint-led design, which was a clever way to design the trial. But they chose to terminate the trial once they'd had 25 endpoints, which meant recurrent TIA or stroke. They were at a relatively high risk of group who had a recurrent stroke risk of around 1 to 2% per annum. So they recruited in North American centers. They recruited quite quickly. They recruited the right type of patients. Patients were very well screened for other types of stroke. They were just typical of the kind of stroke patients that we see, paradox members and patients that we see. But they finished the trial when they had only 25 endpoints. And it's just a shame they didn't carry on until 40 or 50. But in my view, they could have carried on with the follow-up of the study. But they got 1,000 patients, so it's quite a big trial. Depending on which analysis you then use, there was a reduction in recurrent stroke risk of anywhere between 30% and 70%, depending on how you look at the results. But of the 25 recurrent events, they split basically 16 in the medical treatment group and 9 in the device treatment group.
And it's proof that this was underpowered if you can have such a huge relative reduction, and yet it's still not statistically...
It only just, with the secondary statistical analysis, which was the next one they went with, it just failed to reach statistical significance, but only just. But some of the other analyses are highly statistically significant. So I think it's a positive trial. It's a big reduction in stroke risk. But the overall message are these are relatively low-risk patients. Recurrent stroke risk is about 1% per annum if they just take simple antiplatelet treatment, aspirin or clopidogrel, or an antithrombotic drug. I think it's very reasonable to treat people with warfarin. And although they're not licensed for this, it's probably reasonable to use a new oral anticoagulant as well. It's probably reasonable, but it wouldn't be within their licensed indications at the minute. So they're a relatively low-risk group of patients. These procedures probably reduce the risk even lower, but that's only going to work if you've got a very safe procedure with a very low risk of procedural complications. I think if you have any procedural complications really almost at all, then you can easily negate any reduction in risk for the patient, certainly early on. I think you need to take a long-term view to justify these procedures. So if you have a 30-year-old patient with a life expectancy of another 40, 50 years, none of the trials have got that kind of length of follow-up. We're talking about 5 years follow-up, when really we're looking at lifetime risk when we're discussing the risk. And I think if you consider lifetime risk, as long as you know, again, your procedure is safe in the long term, which I think we do now. We've got 15-year follow-up of these patients, and there do not seem to be long-term complications. We've talked about the aortic erosion concern, but that's a very, very low risk for the small PFO devices that we're implanting. So if you know your procedure is safe procedurally and you know the long-term outlook is very good, then I think you can justify it. For me, it's for selected groups of patients. So the trials have identified some groups of patients who are at higher risk, and also the RESPECT trial, I think, clearly shows that those patients derive greater benefit from the procedure. So that would be very young patients at the time of their first stroke, so patients under 35 years of age, patients who've had multiple events, either on their MRI scan or clinically, and particularly patients with anatomical features that indicate a higher than normal risk, which are exceptionally large PFOs, associated atrial septal aneurysms. And there's overlap, but the same thing can be shown for people who've had larger strokes. So if the defect on your MRI scan is more than 15 millimeters, it's a larger stroke. It implies a larger embolic event than a larger PFO. These three things are related. The aneurysms, large PFOs, larger strokes tend to go together in the same patient. They coalesce and indicate a higher than normal risk. And they're generally the patients that we'll consider for closure. The device that we've used for this case has been around for a long time, as you know, well over 10 years. It's well proven. I find it very easy to use, very, very safe. It's completely retrievable multiple times. It's a great device for teaching for your first case, because if it's not in the right place, it's very easy to retrieve and it will not damage the device when you do so. And it's the device they used in the RESPECT trial, so I'd view it as the device with the best evidence. And it's our most commonly used devices. We've got some experience with other devices, but it's much less. And I still continue to use the the St Jude medical device, and I'm not aware of something that is much better. The other thing I'd say is we follow up all our patients, and we'll do a contrast echo at 3 months, a repeat contrast echo at 3 months in all of our patients. And we have found consistently that this device completely closes the PFO in about 90% of people. So we'll find small residual shunts in up to 10% of people. I have not seen convincing data with any other device that's as good as that.